Good evening. My name is Altaf Kazi. I work as Senior Vice President for Acumentis Healthcare. Before I introduce my company, I welcome all of you to this wonderful ACC Konnect initiative. To start the proceeding this evening, let me introduce my company very briefly. Acumentis Healthcare was founded in 2010, fast-growing company and a well-recognized and awarded pharmaceutical company with its presence across multiple therapeutic areas like gynecology, cardiodiabetes, pediatrics, dermatology, orthopedics, and critical care. Acumentis has been known to launch innovative formulations and is a well-respected name among customers in the therapeutic area it operates in. Acumentis is backed by the parent company by name ACOMS, which is the largest India-focused CDMO with 30% market share. ACOMS has about 12 manufacturing plants with 406 dedicated R&D scientists, and ACOMS has about 4,000 commercial formulations across 60 dosage forms. So I take immense pride and privilege in welcoming all esteemed faculty and delegates to this significant ACC Connect initiative. I'm especially thankful to Dr. JPS Sani, Dr. C.K. Ponde, Dr. Shomitra Ray, and our invited international Dr. Gian Luigi Savarese for participating in this program. This special wrap-up session is a deliberation on recent advances in cardiology, featuring late-breaking presentations from the recently concluded ACC Congress. Therefore, let me first welcome Dr. JPS Sani. Professor Dr. JPS Sani is a well-known senior cardiologist and chairman from Sir Gangaram Hospital, New Delhi. Apart from various accolades and awards which he has earned, he has more than 228 national, international publications in index journals and reputed journals. He has received various national awards and orations. Now I welcome Dr. C.K. Ponde. Dr. C.K. Ponde is a well-known senior cardiologist from PD Hinduja Hospital and Medical Research Center, Mumbai. Apart from several honors and accolades he has earned, he has been delivered 350 lectures in various national and international conferences. He has up to 100 publications in national and international journals to his credit. Has worked as a referee for reviewing journals, articles in index journals like JAPI, Indian Heart Journal, etc. Now I welcome Dr. Shomitra Ray. He's a renowned cardiologist from Kolkata, Woodlands Hospital, Kolkata. He's published many papers, review articles, and chapters in cardiology books in India and abroad. Apart from various accolades and honors he's earned, he's in the editorial board of Indian Heart Journal, International Journal of Diabetic Dyslipidemia, has represented CSI in various international conferences. Finally, let me welcome our esteemed international faculty, Dr. Gian Luigi Savarese. Dr. Savarese is Associate Professor of Cardiology and Senior Lecturer. He's the Department of Clinical Sciences and Education, Karolinska Institute. He's a Senior Consultant for Heart Failure, Stockholm South General Hospital, Stockholm, Sweden. Over the last few years, he has published more than 300 articles on top peer-reviewed journals. He is heavily involved in registry studies, Swedish Heart Failure Registry, ESC Registry, and his clinical trials, and he's expert in meta-analysis and big data analysis. Therefore, I would request my honorary chairs to take the proceedings further. I would request Dr. JPS Sani to take us the proceeding further. Thank you.
So I think Dr. JPS Sani is still maybe I request you to start the proceedings. And
I think, yeah.
Okay. So I think Dr. JPS Sani is...
yeah, I got it now. Yeah, thank you, Dr. Guru. I think we go for the presentation by our guest speaker. That will be nice. Dr. Savarese can start his talk, and then we'll have discussion with each other, with my other colleague.
Thank you so much. And thank you so much, first of all, for the kind invitation. It's a pleasure to be with you today. I've been trying to summarize some of the I would say, key findings from ACC presented randomized controlled trials a few weeks ago in Chicago. And I would like to start with the FLAVOUR-2 trial, which I've been pleased to co-author, and I'm involved in the steering committee of the trial. That's on ferric carboxymaltose assessment of morbidity and mortality in patients with iron deficiency and chronic heart failure. Just as a short background, I think it's important to highlight that iron deficiency in patients with heart failure is extremely frequent, with a prevalence above 50%, as shown also in our data, and correlates with mortality and morbidity. And therefore, it has emerged as a treatment target in patients with heart failure and at least reduced and mildly reduced ejection fraction. Here you see a very short summary of the study design of the FLAVOUR-2 trial. So it included, as I reported, patients with iron deficiency, which is defined as according to the guidelines, which means ferritin, low ferritin levels, or low ferritin levels together with a T-set below 20. So whether it's between 100 and 300, the ferritin, also a T-set less than 20% is required. Otherwise, if we have only very low ferritin, we can define by itself iron deficiency. So in these trials, the traditional definition for iron deficiency was used. And what it was a little bit new to see is that the primary endpoint used a very interesting approach, which was actually having 3 sub-outcomes, if we can define so. But in order to have a trial which was statistically significant, it was required that the alpha, so basically the p-value for each of these 3 outcomes, would have summed up to less than 0.05. And you see that the three components of this primary endpoint were cardiovascular death or heart failure hospitalization, analyzed as a time to event analysis with a Cox regression model, recurrent heart failure hospitalizations analyzed with the LWYY method, and actually also the composite of cardiovascular death or heart failure hospitalization, but in the subgroup of patients defined according to a T-set less than 20%. The reason for that is that some meta-analyses have been showing that probably the real population benefiting of ferric carboxymaltose and IV iron in patients with heart failure are those with low T-set. So secondary outcome were quality of life, functional assessment, and in particular the change in this outcome from baseline to month 12. And here you see the results for primary endpoint 1 and 2. The primary endpoint 1 was we cannot say significantly reduced for the reason I explained earlier, but you see it had a p-value of 0.04 with an hazard ratio 0.79, highlighting a possible 21% reduction in risk of cardiovascular death or heart failure hospitalization together with ferric carboxymaltose as compared to placebo. On the other side, you see the primary endpoint number 2 with a p-value of 0.009, so extremely low, with a rate ratio highlighting a relative risk reduction of 35%, and a rate ratio that's at 12 months, and over the entire follow-up, a rate ratio of 0.80, highlighting a relative risk reduction of 20%. And as I said, in order to have a positive trial, it was required that all of 3 outcomes in terms of p-value would have summed up to less than 0.05. And at the moment, if you consider only this outcome, we are still below that p-value 0.05. But when we consider the third component, actually we see that we exceed the threshold of 0.05 when we sum up all the different p-values, and therefore the trial cannot be overall considered as positive. But you see that indeed for this primary outcome number 3, which is cardiovascular death or heart failure hospitalization, in the subgroup of patients with TSAT less than 20%, actually p-value was 0.07, highlighting a no significant relative risk reduction of 21%. And other secondary outcomes important, I will say in particular when it comes to iron use, are quality of life and functional assessment. And you can see the quality of life was statistically significantly improved by ferric carboxymaltose as compared to placebo in terms of AQ-5D score, and also when considering the patient-reported global assessment of well-being, which is another measure. There was no statistically significant change in comparison between the treatment and the control arm from what it comes to New York Heart Association class and 6-walking test. But you see that actually also the treatment was safe because there was no increased all-cause mortality or cardiovascular mortality, with the treatment as compared to the control being these two outcomes, the safety endpoint for the trial. So we can conclude by saying that the FAIR-HF showed, in terms of outcome, results very similar to what previously shown in that firm, AHF and Ironman, although not reaching statistically significant. And the FAIR-HF2 suggests that both definitions for iron deficiency are actually useful, and it also suggests that the FAIR-HF, that the trial suggests that the benefit of IV iron therapy on quality of life and patient self-reported health status are consistent with previous evidence. And very important is the result of the meta-analysis, which has been very recently published as well, including FAIR-HF2 in Nature Medicine, actually showing that when we pull all the trials together, we do see a statistically significant reduction in risk of cardiovascular death or heart failure hospitalization with IV iron as compared to placebo. That's the overall evidence in the field. Another trial which is quite important, which has been presented, is the API-CAT study, which means extended anticoagulant treatment with reduced versus full dose of apixaban in patients with cancer-associated venous thromboembolism. So this is a very important issue in clinical practice, and I think this trial is very important. So patients which were randomized were patients with VTE, with active cancer, who completed at least 6 months of anticoagulant treatment. And then at that point, they were randomized to apixaban 2.5 milligram twice daily or 5 milligram twice daily. And 12 months was end of treatment, and started a 30-day follow-up after this phase. And very important was stratification according to site of cancer and index VTE. That's very important because it's assumed that these two variables could have impact the efficacy of the treatment, and therefore randomization happened according to a specific procedure which is called stratified randomization. And here you see the results of the trial. The authors were very humble, and they started with testing non-inferiority. You see statistically significant non-inferiority, which means that reduced dose was not worse than full dose. But then the authors also assessed here in the primary efficacy endpoint was indeed recurrent symptomatic VTA or incidental VTA. That's very important to remember. Then the authors also assessed for superiority key secondary safety outcome, which was a composite of MB and CRNMB, and you can clearly see that actually, in terms of superiority, apixaban reduced dose was actually better than the full dose, actually highlighting that using a low dose of apixaban in this particular clinical setting might be particularly useful because it's not non-inferior as compared to the full dose, but at the same time, it also leads to less bleeding. Another important trial which has been discussed is the blind stride trial, has been presented indeed during the ACC by Professor Bonaca, and that's about the use of once weekly subcutaneous semaglutide on functional capacity in people with type 2 diabetes and PAD. And as you know, patients with type 2 diabetes are at very high risk of PAD. So this is again results which are very clinically relevant. And you see here the study design. So we see patients, of course, this was a randomized controlled placebo trial, 1,300 patients which were screened and 790 randomized. Patients who were randomized were patients with type 2 diabetes, PAD, and intermittent claudication, defined as you see here in this slide. And intervention, as I reported, was 1 milligram subcutaneously once per week of semaglutide for 52 weeks as compared to placebo. And the primary and secondary endpoints are reported here. So they were the change in maximal walking distance from baseline to walk 52, so an improvement in terms of how long the patients could walk, and also quality of life measures and pain-free walking distance. And here we see the results of the trial. So you see that the trial was actually very successful. Semaglutide improved the primary outcome, which was the maximum walking distance as compared to placebo. Also when actually these changes was measured as median difference and as mean difference, and also the secondary outcomes were improved by semaglutide as compared to placebo. So I will say one more successful trial on use of GLP-1 receptor agonist in a population with type 2 diabetes, but with outcomes which have not been investigated earlier, and also in a subpopulation which was not clearly assessed earlier, which is patients with PAD. Here you see a summary again of the function, quality of life, and hemodynamic outcomes. All of them favors semaglutide. So very successful trial, which leads to the conclusion that semaglutide is first therapy to reduce major adverse cardiovascular events, improve cardiometabolic and kidney outcomes, and enhance walking capacity, symptoms, and quality of life in patients with PAD and type 2 diabetes. So very important trial as well. Then we go on to slightly different topic. We go to, there have been so many trials on this topic, but I think this is particularly simple and I think clinically relevant. And the aim here is to compare different duration of dual antiplatelet therapy after coronary stenting in either high or low bleeding risk population. Because when we said DAPT, the real problem is understanding the balance between ischemic risk and bleeding risk. And here you see the design of the study. So these were 4,800 patients eligible for receiving PCI in Korea. So the trial was run entirely in Korea. And randomization was stratified by bleeding risk. So up you can see high bleeding risk, and below in this slide you can see low bleeding risk. And you see that based on the bleeding risk, patients were randomized to these two different strategies. So DAPT 1 month versus DAPT 3 months, followed by single antiplatelet for the high bleeding risk subpopulation, and for the low bleeding risk population, 3 months as compared to 12 months. And let's go on and let's see the primary endpoint of the trial. So we see very clearly that in the high bleeding risk at 1 month DAPT didn't meet non-inferiority compared to 3-month DAPT for NACE. And 1 month DAPT was inferior to 3-month DAPT for both NACE and major adverse cardiac or cerebral events at 1 year. And there was no significant difference in any actionable bleeding between the two groups. So these are actually the results for the high bleeding risk population. When it comes to the low bleeding risk population in the trial, you see that 3 months DAPT reduced any bleeding compared to 12 months, so it was better for this outcome, and there was no increase in NACE with 3 months as compared to 1 year DAPT in this subpopulation. So just to summarize, it seems very clear that regarding of the bleeding risk, a 3-month DAPT regimen appears to be optimal and therefore default during duration for DAPT after PCI, as it strikes a balance between thrombosis and prevention and bleeding risk. So I would say simple trial, but very clinically relevant message. And then we come to, I would say, one of the highlights of the Congress. Again, a trial on GLP-1 receptor agonist semaglutide. This is the sole trial. Actually, here we have oral semaglutide, which is tested against placebo for cardiovascular events in patients with type 2 diabetes with atherosclerotic cardiovascular and or chronic kidney disease. So more or less a setting where we know that GLP-1 receptor agonists work, but we don't have evidence for oral semaglutide. So this is the focus here is indeed the oral version of GLP-1 receptor agonist. And you see here that you have a mega trial with 10,000 patients. Key inclusion criteria, as I said, was type 2 diabetes, glycated hemoglobin between 6.5 and 10%, and history of at least one of the conditions reported here, which are coronary heart disease, cerebrovascular disease, symptomatic PAD, and chronic kidney disease. And as I said, the primary outcome was a MACE, traditional MACE outcome, so cardiovascular mortality, myocardial infarction, stroke as assessed usually in these kind of trials and population. So 4,825 patients per treatment arm. We do see that there was a kind of, I will say, valuable loss to follow-up or number of patients which didn't complete the treatment. As you see here, it's around 25% overall in the trial. But in any case, let's see the primary outcome of the trial. As I say, cardiovascular death, non-fatal myocardial infarction or non-fatal stroke. You see that the curves are diverging very nicely. They seem to diverge so nicely, also just because you see the y-axis has been very, it's just between 0 and 14%. It makes seem everything bigger than what it is. But in any case, the trial was positive. There was a 14% relative risk reduction for the primary outcome, but beyond checking relative risk reduction, I always invite when we interpret trial to see absolute risk reduction, which was 2% over 3 years with a number needed to treat of 50, which is quite high. It's quite a lot. Here you see the confirmatory secondary outcome, and this was instead non-statistically significantly reduced by the treatment, so oral semaglutide as compared to placebo. And this was a composite of cardiovascular death, kidney-related death, worsening renal function, persistent worsened EGFR, and chronic kidney replacement therapy. So this was not statistically significantly reduced. So just to conclude, oral semaglutide was superior to placebo in reducing the 3-point MACE in patients with type 2 diabetes and atherosclerotic cardiovascular disease and or CKD. And the overall safety profile of oral semaglutide was similar to what observed in previous trials with semaglutide in general, so there were no particular safety signals. And of course, from this trial, we get new information regarding a specific subpopulation and a specific type of drug, which is the oral form of semaglutide. And let's change a little bit topic, and we switch now to hypertension. And here we have Lorundrostat, a novel aldosterone synthase inhibitor. So I would say a lot of expectation of this new, relatively new treatment class. This is the time of a population with uncontrolled hypertension on a standardized antihypertensive medication regimen. So this was the study design. So you see patients were randomized to placebo against Lorundrostat 50 milligrams and 100 milligrams. So here one other purpose was to understand the optimal dose for using Lorundrostat. And the study's design is a little bit complex because, as usual in trials on hypertension, there is the problem of the background therapy. And in such a trial, you really need to have all patients more or less on the same background therapy. So when the patients were enrolled, actually were switched to a standardized regimen, including idapamide or mesartan and or with or without additional amlodipine. Were randomized to, once they were switched to this treatment, were randomized to placebo, Lorundrostat 50 or 50 to 100 milligram daily. And there were possibility of seeing the effect of the drug in an open label extension of the trial, or of course at just at the end of the treatment phase, which was 12 weeks. And what you see here is the primary endpoint, as usually in trials on hypertension, is the change in 24-hour average systolic blood pressure. And you see that the Lorundrostat 50 milligram was very successful in reducing systolic blood pressure as compared to placebo. Very interesting to see that with 50 to 100 milligram, there was no additional reduction in blood pressure. But let's see the secondary endpoint, which was actually a reduction in 24-hour average systolic blood pressure at week 4. And here we see once again that Lorundrostat actually reduced very much systolic blood pressure, meaning that the reduction happened very early, immediately after the start of the treatment. The treatment was safe. There was numerically some few more adverse events with the higher doses and with no additional value of the higher doses. And therefore, probably the best conclusion is what reported here is that Lorundrostat lowered 24-hour blood pressure among patients with well-treated, uncontrolled, and true-resistant hypertension, and the dose escalation strategy from 50 to 100 actually didn't bring any additional benefit, but just led to numerically higher number of adverse events. So I would say till now we have been seeing quite relevant results, many positive trials. Unfortunately, FLAVOUR-2 was not really positive, but seemed positive, probably because of the specific design of the primary outcome. But let's see one more important trial. This is the FLAVOUR II trial. That's a comparison of angiography-derived fractional flow reserve-guided and intravascular ultrasound-guided percutaneous coronary intervention strategy. Again, a very relevant clinical issue that we meet in daily clinical practice when we see these patients coming to our labs. You see that the trial enrolled around 1,800 patients, which were randomized to the angio-FFR group or the IVOS group. The population which was enrolled were actually, it was consisting of patients with suspected ischemic heart disease and with at least 50% stenosis in epicardial coronary arteries, measuring at least 2.5 millimeters by visual estimation on coro-angio. And here you see the primary outcome of the trial, indeed comparing these two procedures, and you actually see that the two procedures were basically just the same. So IVUS and angio were similar in actually mortality, recurrent angina, and so on. Here you see additional results in the medical treatment PCI arm. We can just skip this, it's not key. But let's see the conclusions. The conclusion is that the angio-FFR guided comprehensive PCI strategy encompasses a decision-making and stent optimization, is not inferior to the IVOS guided strategy with respect to the composite endpoint of death, myocardial infarction, or revascularization at 12 months. So one or the other are actually seems to be actually more or less the same in the setting of this trial. In patients with heart failure, this is a very frequent question. So should we use liberal fluid intake or fluid restriction? And in many clinics, we are used to use fluid restriction to treat patients with heart failure, trying to avoid decompensation. In this trial, these two approaches were actually compared. These enrolled patients with a diagnosis of heart failure according to the ESC guidelines, symptomatic patients with NIA class 2-3. The primary outcome was health status at 3 months as assessed by KCCQ OSS, which was also adjusted in further analysis with ANCOVA. And secondary outcomes were thirst, distress, assessed by this specific scale. Primary outcome of the trial. So you see that health status actually in patients with liberal fluid intake seem to be better. So quality of life seemed to be better as compared to those receiving fluid restriction. And you also see that, as expected, in the fluid restriction arm, the thirst distress scale was actually higher, and also overall, the different quality of life indicator was actually worse in patients with assigned to the arm randomized to fluid restriction. So there are trends for this outcome favoring liberal fluid intake. Slight improvement observed, but primary outcome was not met. You have seen that the curve was not really steep, but actually there were trends. And the thirst distress, as expected, was actually higher in the fluid restriction group. Safety events, they were no different. And we need definitely more trials regarding this specific issue in patients with heart failure. And I think one more highlight of this Congress is definitely the trial here reported actually assessing the use of Dapagliflozin in patients undergoing TAVI, which is a kind of patient setting that we see, I would say, quite often in daily clinical practice. This was a trial which was run in Spain in 39 hospitals between 2021 and 2023. And you see here the study design. The study enrolled patients with a history of heart failure, plus at least one of the following: renal insufficiency, diabetes or left systolic dysfunction. So in few words, this trial just enrolled the population where we know that SGLT2 inhibitors are already of benefit, but this was the specific setting following a TAVI, and how to say, SGLT2 inhibitors in this environment have not been clearly investigated. The trial enrolled around 1,200 patients, and here you see the results for the primary outcome, which was death, a composite of death or worsening heart failure at 1 year. And you clearly see success with dapagliflozin as compared to placebo, with the usual hazard ratio that we see with SGLT2 inhibitors in this setting, which is around 0.75. And you also, the trial was, of course, not really powered to see all-cause mortality, although you see there is still an hazard ratio, which is 0.87, and you see a strong reduction in worsening heart failure in patients randomized to dapagliflozin as compared to the control, which is, I would say, very much expected. So the conclusion is in patients with aortic stenosis undergoing TAVI and at risk for heart failure, dapagliflozin was safe and reduced the incidence of all-cause mortality or worsening heart failure as compared to standard care. And we are going to an end. I think many trials have been presenting during the ACC, and this is only a selection. So there are some more that unfortunately we left behind. This is the PROTECT-TAVI trial. It's about routine cerebral embolic protection in patients receiving a TAVI. This was a study sponsored by the British Heart Foundation. And you see that here the intervention was this specific device, which consists of filters which are placed percutaneously from the right radial or brachial artery in the brachioencephalic artery and the left common carotid artery. So the aim of using the device is to actually prevent a stroke during a TAVI, and therefore in this trial, patients were actually implemented with the use of the device before receiving, immediately before receiving the TAVI. And you see here that the primary outcome as expected was, of course, stroke in the short term, so at 72 hours immediately after a TAVR. And around 7,600 patients randomized, so very big trial in many centers in the UK. And the trial was neutral. And you see that although in some subgroups there might seem to be tendency to have benefit with the CEP, which is the intervention, which is in particular in patients with a higher Euro score, actually all of this was not statistically significant, so neutral trial. And there were neither difference in terms of secondary outcomes, which were death, no fatal stroke, and here, as reported here. So just to conclude, the routine use of sentinel CEP, which was this intervention, doesn't really prevent stroke, and these results are consistent with previous evidence, and therefore there is no evidence supporting a recommendation for routine use of CEP in TAVR. And I will say that probably we might stop here with the presentation to allow for some discussion, or do you prefer that we see the last trials? I think we are more or less at the end. What is the preference?
You can show this slide.
Okay, that's great. So we go to the reverse IT trial. That's a very important trial, although not full results are delivered yet in a publication. This is about actually reversing the effect on coagulation of on aggregation with the ticagrelol. And you clearly can see that after using this specific drug, actually there was a very much decrease in inhibition of PRU, which shows the clear benefit of using this drug for effective hemostasis when it's needed, particular close to surgery or procedure, or in case of major bleeding, whether patients are on ticagrelor. And I think this is the very last one. This is about comparing clopidogrel versus aspirin for long-term maintenance monotherapy in patients with high ischemic risk after a PCI. Very simple trial. It compare actually monotherapy with clopidogrel versus aspirin after actually a phase of DAPT, and you can clearly see that there was actually better prevention of the primary outcome of the trial with clopidogrel as compared to aspirin. So here you see all the outcomes which were assessed. So when we consider actually a composite of death from cardiovascular cause, myocardial infarction or stroke, there was a clear benefit of using clopidogrel as compared to aspirin after using DAPT in this specific subpopulation. There was no statistical significant reduction of the individual outcomes. Probably the power was just not enough. So these were the results of the Smart Choice 3 trial. And that's all from my side. So
Thank you very much, Dr. Savarsi. You have, in fact, presented almost all the key important trials which have been published, and you have presented them in a very nice manner, given us a take-home message. And most of this trial have got a clinical implication. I mean, they have an impact on clinical practice.
Thank you
the last one was very important, that after 1 year, clopidogrel is better than aspirin, that we used to think other way around earlier.
Right.
And so I will now involve my colleagues also. Before that, I will just say that one sentence each trial, that which is a Zenith trial, where this sotatercept was used as a new drug, active in signaling inhibitor for pulmonary arterial hypertension management. So over and about the dual or triple therapy for PH patient of advanced pulmonary arterial hypertension, they have shown this drug has shown to be adding benefit to the outcome of the patient. The second trial was the rivaroxaban versus warfarin in a large anterior MI with LV clot. Before PCI, the clot was much higher, but after PCI, the incidence is down to 10% now. So rivaroxaban was compared to the vitamin K antagonist and shown that rivaroxaban is effective. So NOACs are now looking that they are also better drug than vitamin K antagonist in the setting of LV clot. And thirdly, the olezarsen, the new small interfering messenger RNA drug for the management of high triglycerides. I mean, triglyceride up to 500 milligram with atherosclerotic cardiovascular disease or multiple risk factor, and another group was more than 500 milligram of triglyceride, basically to prevent the pancreatitis. And this drug has shown, olezarsen shown that it is a very effective drug, and it reduces triglyceride by almost 70 to 80%, which was not possible with the fenofibrate and icosapine. So I think now I will request my colleague, Dr. Pandey, you're here with us. And the first 3-4 trial, which Dr. Savarsi has shown about the iron supplement, then the venous thromboembolism, malignant strides, these 3 trials, important trial. You have to make any comment, Dr. Pandey?
No, I think from the point of view of our perspective, Indian perspective, the low-dose apixaban trial is pretty useful. It has given a useful message that you can prevent recurrent venous thromboembolism in patients with malignancy with a low-dose apixaban, with reduction in net adverse clinical events, that it reduces bleed and is equally efficacious. So that I think is a very, very...
I would like to ask your experience, because that if suppose in a non-malignant setting,
Yes.
I mean, we do get sometimes patient of unprovoked DVT with pulmonary thromboembolism, and we have to give them almost lifelong anticoagulant treatment. So some of the guidelines have suggested now that after 6 months or so, you can down titrate the dose to like 2.5 milligram or the rivaroxaban 10 milligram or the or 110 milligram twice a day of dabigatran. So you think that in a non-malignant setting, this rule should be applied or not? It looks very safe because keeping it with the safety and the efficacy for long-term, lifelong, where the bleeding risk will be less, but it will be equally effective. Do you think that it can be one of the way to manage patients non-malignant setting? Your opinion?
I think so, sir. I mean, if it has worked in a highly prothrombotic milieu, possibly it will work in unprovoked unprovoked venous thromboembolism, provided there are no other background risk factors like antiphospholipid syndrome or proteinase deficiency, where it becomes mandatory to use VKS. So yeah.
So that is that. And regarding the STRIDE, they have taken we participated in STRIDE. It was a little difficult trial because we have to use the TMT and then ABI and TBI also. Toe bronchial index was also done in this. We gave 11 patients out of 33 from our country. But do you think that it is a diabetic setting? In a peripheral vascular disease, in a non-diabetic setting, as we see now, the data of the GLP-1 analog is coming even in non-diabetic setting. Do you think that this trial can be helpful? This drug will be helpful. At the same time, I will ask you about the SALT study, large study on the oral semaglutide, which we are using in our country. And again, that is in the obesity. This are used in the CAD setting. With the and like you select trial, you see there was CAD but no diabetes. CAD with obesity, the semaglutide was used. So do you think that this oral semaglutide will also be effective the way in select study we have found the results of the injectable subcutaneous injection? Because what I want to say that in diabetic and non-diabetic setting, both those who are obese.
You want me to answer that question, sir?
Yes, I want your opinion.
Opinion. I think SGLT oral SEMA is moving in more or less the same way the SGLT2 inhibitors have their journey. They started with oral anti-diabetic drugs, then they proved their efficacy in renal outcomes, then they proved their efficacy in heart failure with preserved ejection fraction as well, and now they are proving their efficacy in many other spheres of cardiology, just like this TAVI trial with Dapagliflozin. So I think oral SEMA is moving more or less the same direction. And even now, the Wegovy, which is going to come, a subcutaneous injection of SEMA 2.4 milligrams as a pure anti-obesity drug, is one of the evidences that many other spheres other than diabetes will be addressed with the GLP-1 receptor agonist, particularly semaglutide. Yeah,
it looks like, because the obesity is a good drug to reduce the obesity, and it is increasing.
If I may, it's an interesting point. Now we have trials on injectable GLP-1, and then we have trials on oral. But, according, I guess, to, the evidence, we cannot really use one rather than the other it makes very much sense. But unfortunately, since we are so much data driven, we can only actually apply use oral in the setting where oral was assessed, and vice versa. And that's actually I think a little bit like an important question, and I think we should also discuss the implication for the patients, whether the patients want to receive one treatment rather than the other. And this open to questions also about potential off-label use of one rather of the other.
Thank you. Dr. Samitra, you're here. And that's right. Your study about that synthase inhibitor, which we are using now, the clinical trial is going on in the Dextrostat at the moment with us. We are doing that study. And this is another molecule. And then the drug seems to be useful in resistant hypertension or uncontrolled hypertension with background of 2 or more antihypertensive drugs. So do you think that this drug is useful? And What your opinion that this drug will be in future will be useful in clinical practice?
Yeah, good evening, Professor Severesi, JP and CK. I'll answer that, and I'll have a quick overview of some of the other trials as well.
Yes.
Lorundrostat, the aldosterone synthase inhibitor, nowadays almost 80% of the newer focus on antihypertensive is targeting the RAS system, whether it is angiotensinogen, whether it is aldosterone synthesis. So they're actually targeting the RAS system more and more. And it is one of the armament. But what I was surprised a bit that it is on, everybody was mandated to take olmesartan in the background. So it is a second RAS inhibitor, you can say, that it's not replacing any RAS inhibitor. It's used on top of another RAS inhibitor already on board. So that's a bit surprising, the aldosterone synthase inhibitor. Perhaps it will replace MRA in resistant hypertension later on. And it is one of the promising molecule. 50 milligram is as good as 100 milligram. So I think many of these will be in the competition, and some will stay in the fight at the end of the day, whether it is angiotensinogen inhibitor or aldosterone inhibitor. MRA, finerenone is a strong candidate nowadays in this field as well. So even in resistant hypertension. So it is a big competition going on. And let's see who does what. Appears to be
the other question I would like to ask you about the fluid restriction study.
I am going to that. Actually, that is very interesting. That is very interesting, JP. Very, very interesting. That study I did not find very encouraging. I'll tell you why. 80% of the people who are in stage 2, not NaOEH 3. Okay. So we cannot generalize that in heart failure patient give liver fluid. Number 2, what was the difference between the fluid? One is 1.45 something, that is approximately 1.5 liter a day, and it is 1.7 liter a day, 1.75. So when you say your patient that take fluid liberally, they will take 2.5 liters, they will take 3 liters. It's just 1 glass of water extra in a day. And you can't call that a liberal fluid intake. 1.5 versus 1.7 may be statistically significant, but it cannot be implied in the general practice. And it is a wrong message if we say, okay, for all heart failure symptomatic patient, you can take fluid liberally. That is not at all true. It is for stage 2 patient, and from 1.5, that is about 6 glass of water to 7 glass of water, not 10 glass of water. But it has got a reverse implication, JP, as you were saying in India. We already encourage 2 liters a day, because in our hot summer days, 1.5 so far off, even 1.7 is not good enough. People will be dehydrated. There will be pre-renal failure. There will be high rise of urea and fall of blood pressure. So we many times encourage 1.8, 2 liters a day in our hot sunny days, particularly the people who are not in cold chain like ourselves. Those people who work really work and not do academics like us. So I think for those people, there will be wrong message to say that just go and take whatever you like. I say there should be some restraint on that. And perhaps thirdly, JP, the clopidogrel issue is very, very nicely addressed this time, that whether high bleeding or low bleeding, 3 months is a good compromise. And it saves the complexity in clinician's life. Forget about 1 month, forget about 1 year. Stick to 3 months and you will be a gainer perhaps. And perhaps clopidogrel is always good compared to aspirin when you are using one. Though what happens to clopidogrel resistance, I never understand. Still today, I don't understand what happens to those 30% unfortunate people who are clopidogrel resistant. What happens to them once they are on only clopidogrel only regime? So it is a paradox to me. So that's my take.
I agree with you. That's what clopidogrel, we used to think that even in Korea, where the study was done, there also the clopidogrel resistance is slightly higher. And our own study in India, which we did a few years ago, again showed partial resistance to clopidogrel, but yet clopidogrel showed superiority over aspirin after 1 year. Now I want to ask a question.
No, I think, sir, can I want? One point can I add, sir?
Yes,
So
yeah.
so many de-escalation trials in DAPT had unguided de-escalation to clopidogrel from ticagrelor, and
Yes.
yet the ischemic events are not increased. Just stating that the laboratory resistance to clopidogrel and the clinical are two different entities.
Absolutely.
Two different entities.
Yes, sir.
And I
No,
think
I want one question.
this trial is a complete replication of the Capri, the
Yeah.
original trial by Deepak Bhatt, where
Yeah.
in patients with ischemic events, clopidogrel monotherapy fared superior to aspirin monotherapy.
So I want one question for all three of you. After 3 months, if you want to give single antiplatelet, which one will be the drugs? Aspirin, clopidogrel, or ticagrelor?
After 3 months, sir, if the setting is of ACS, if you have done a plastine ACS, my inclination will be to ticagrelor for the first 1 year as a monotherapy, if the P2Y12 inhibitor. And if you have done a complex angioplasty like Lepmin, LED crossover, or some culotte technique, or LED big diagonal bifurcation, etc., then I would still incline towards ticagrelor monotherapy until 1 year. And beyond 1 year, of course, then the ground is open. Maybe we can go to compass regimen if there are factors guiding compass, or you can go to clopidogrel monotherapy if the ischemic risk is low and the bleeding risk is high, or something like that. But in an ACS scenario and a very complex PCI done as an index procedure, after 3 months of DAPT, it should be P2Y12 inhibitor DICA. That will be our center's usual practice.
Dr. Savarese, what is your opinion, sir?
No, I think this is very reasonable. I completely agree. This is a very high risk population. I think the use of ticagrelor here for this phase is really required, and then later probably I might go for probably clopidogrel, also according to the results that we have been seeing here.
So after 1 year, is there any chance of giving now, like compass trial, giving dual antiplatelet versus DAPI? I mean, giving rivaroxaban 2.5 twice a day with aspirin.
That's a very good point. I mean, it's we have the result of the trials, but actually, I don't know how it is in India, but they have not been really implemented in other countries.
Really? I just add that while you are giving from 4th month to 12th month ticagrelor, it is 90 milligram twice daily, not 60 milligram twice daily.
Yes, 90.
That is very, some people.
Yeah, that's what you have.
And of course, people, yeah.
So it looks like with this results of this trials where we only up to 3 months we have to give dual antiplatelet in both this setting, it becomes easy for us to go for surgical therapy, surgical treatment, which we sometimes wait for 1 year to stop the drug and go for the. So no, suppose a person has to go for an emergency surgery at 4 months post PCI, and he's on ticagrelor only, and shall we stop it and go for surgery, or what to do for that? How to manage this type of patient? Emergency surgery, patient is on single antiplatelet drug, recently undergone PCI.
No, that's a real clinical dilemma, sir, and it's an unresolvable dilemma. And I think if the surgery is truly intraperitoneal or vascular or a neurological something, then you are in a big mess over there. But other surgeries, I think, by stopping almost 36 hours of tika, people have done in my hospital, and what they do is they give 2 or 3 or at least one single donor platelet just before the surgery, starting an hour before the surgery, finish the surgery, and then hand over the patient back to the ICU.
That's
now
right.
you have got the reversal agent now, just published.
Yeah. But it is I don't know, is available commercially.
Not yet.
Not yet for that. Okay. Because this will be a useful drug, no doubt. If you're using ticagrelor, as it will be, as Dr. Pandey has said rightly, in most of the patients, probably ticagrelor will be the drug to be used as a single drug for 1 year. I think in that setting, this reversal drug will be very useful in such clinical situation. And suppose patient gets bleeding on ticagrelor, and now you have stopped it, and then you have to restart the drug. Like, for example, we have therapeutically managed his ulcer in the stomach or something like that. Or, I mean, we have to start. Shall we start again on that, or shall we give clopidogrel now?
De-escalate.
I think we de-escalate and reduce, give clopidogrel rather than ticagrelor in that setting.
Yes.
Because sometimes we do see. So, is there any role of prasugrel as a single drug after 3 months? Because this is also used very commonly in clinical practice.
Is more powerful than ticagrelor, and I think it's more as far as bleeding is concerned.
Yep.
Yeah. So, Dr. Savarse, any your final point? I think running out of time.
No, I think it was very good discussion. I think we had very, I think clinically relevant trials. These are really clinical questions, right, that we have every day. And it's good to have clinical trial answering these questions. So I think this has been very fruitful.
Thank you. Thank you. Over to Raghu. We are through. And
yes, sir. Yes.
We have one question from the
your
doctor.
side. And thank you very much.
Question from doctor in the chat box.
From India, and thank you, Dr. Savarse, for a brilliant presentation.
Sir, Mr. Altaf is saying that there is a question in your chat box.
Okay.
Question has been answered. Is Lorundrostat applicable for hypertension patient? Yes, that is the whole purpose of.
Yeah, and it's mainly for resistant hypertension. That's the target.
Yeah. Okay.
Any other question? I can't see.
That's it, sir.
So there's one more which came now just now.
What is written? Rosuvastatin. What is the question?
What is rosuvastatin different between atorvastatin?
Water soluble and the fat soluble.
Yes.
And efficacy by probably Rosuva slightly more. Like this, 40 Rosuva is equal to 80 atorva. And so we have seen that is the basic difference. And
Dapagliflozin and empagliflozin. The debate will go.
that debate is that AMPA has two strengths available, 10 and 25, may be more useful for diabetologists. But the DAPA is one strength available. May not be very useful in patients who have got uncontrolled diabetes. Probably we cannot step up the dose of DAPA, which is not available. But the AMPA has an advantage. It is 25 milligram. So I don't find otherwise any difference between the two.
Yeah. So, Dr. Kazi?
Yeah, I think there. Raghu, is there any question more than?
No more questions, sir. It's
Okay.
Yeah.
Okay.
So, sir, thank you so much. I mean, before I end, let me put a small thank you note on behalf of Acumentis, which is, we have these two important divisions, Noveltis, Novexa. Sir, let me first thank all the 970 participants on a weekend. There are 970 participants who are listening to, this good discussion we have on this ACC Konnect initiative from all over India. Let me express my sincere gratitude to the respected chairpersons for participating in this program. Despite their busy schedules, Dr. J.P. Sani, Dr. C.K. Ponde, Dr. Soumitra Ray, and to our esteemed speaker, Dr. Gianluigi Savarese, for consenting to be a part of the program, despite his very hectic engagements all over the world. It was indeed very enriching presentation and a very engaging discussion, sir, which we just witnessed now with chairpersons. In the same breath, sir, let me also thank my entire team, my Noveltis, Novexa sales and marketing team, dedicating their time towards seeking, doctors' registrations and, making them attend this important event. And it is the interest of continuing education and for the benefit of medical professionals across India. So thank you once again so much, sir. Thank you so much.
Thank you. Bye-bye.
Thank you so much, sir. Thank you. Bye.
Bye.
Thank you.
Yeah, thank you, Mr. Kazi.
Thank you. Thank you.
It was well done and good conclusion also.